Yeah.
Добрий вечір. Сподіваюся, що мене всі чують. Зараз я спитаю в нашої команди, чи мене чутно. Так, мене чутно. Добрий вечір всім. Мене звати Катерина Булавінова, я медичний експерт дитячого фонду ООН ЮНІСЕФ в Україні. І ми продовжуємо цю серію вебінарів. До того, як я передам слово професору Фегерту, бо сьогодні я відкриваю цей вебінар сама, бо пані Оксана в дорозі наразі і не могла зі мною його відкрити, і пані Ірина десь теж наразі у Львові. Тому я буду відкривати його сама. Ми дуже раді, що ви до нас приєднуєтесь в такій великій кількості, і це вечірні часи, тобто це ваш вільний час, ми це дуже-дуже цінуємо. Декілька адміністративних оголошень. По-перше, будь ласка, не пишіть свою пошту в коментарях до цього зуму. Це нічого не дасть для того, щоб ми могли потім надсилати вам сертифікати і також вести комунікацію. Ви заповнюєте свою пошту в спеціальній анкеті, але не в коментарях до цього зуму. Це перше. По-друге, ви можете писати ваші питання в коментарях по ходу, і наприкінці я буду їх всі зачитувати, і перекладачі будуть їх перекладати для шановної пані професора Beate Herpertz-Dahlmann і для пана професора Jörga Фегерта. І вони будуть на них відповідати. Ще раз вам всім дуже дякую, що ви доєднались до цього вебінару. Запис цього вебінару також буде на YouTube-каналі доктор Булавінова. Ви можете подивитись, поширити колегам запис цього вебінару. І він буде як українською мовою, так і в оригіналі. А наразі я передаю слово професору Jörgu Фегерту.
Yes, thank you very much, Katja. It's a great pleasure today to present to you my esteemed colleague and dear friend Beate Herpertz-Dahlmann.
Я не розумію, я зам'ючена чи ні.
Studies in Bonn. She was trained first as a pediatrician in Cologne, and then she started her career in child and adolescent psychiatry in Marburg, but she also had a stay at Stanford.
Я не слышу Йорга вообще.
In the US, and then in 19 adolescent psychiatry, psychosomatics, and psychotherapy in Aachen. And she was president of the German Society of Child and Adolescent Psychiatry in the years 2004 and 2005, and later she had a wonderful congress in Aachen. And then she was on the board of our European Society, ESCAP, and served on the board from 2007 to 2015. She was one of the co-editors of the German Journal of Child and Adolescent Psychiatry. She was very influential in research. She served as an expert to the German research funds, but she's really famous for her work in the clinical field, in the guideline construction in Germany and in Europe for eating disorders. And she did so many things for these patients. She changed our way to treat these disorders with new forms of treatment. And I'm very glad, Beate, that you took the time to do this presentation this evening. And the floor is yours. Thank you for being here. Thank you.
Yes, thank you so much for this very nice introduction. And I'm really proud and happy that I may present a little bit of my research, but not only about my research, but I will also try to give you some important knowledge about anorexia nervosa. And I really hope that you will profit from my presentation. Well, I think Jörg Fegert already introduced me quite well, so I will make it short. I'm living and working in Aachen. As you can see, Aachen is at the western border of Germany. It is very near to the Netherlands and to Belgium. And it has become famous by its very old cathedral, which was built by Charles the Emperor, which you probably know. And this is the very big university clinic in which I'm working, and this is my department. It was built in a very old farmhouse from the 16th century, and eventually we have got a new building too. So you know where I live and work. But now I will refer to anorexia, which is our theme tonight. And I think many of you have already heard of the two first describers of anorexia nervosa. It was Charles Lassac in France, and only very bit later, Sir William Gull in England. And Sir William Gull did a very famous publication. He wrote about a girl which he had seen in his practice. He wrote that this girl was 14 years old and she came to him and was very starved. And he asked the parents to refeed her, and they gave her meals every hour and also some beer, which I would not suggest that you should do that. And she gained weight again. And she looked much better 6 weeks later. However, I think that was a sort of miracle healing. I never managed to heal a girl with anorexia nervosa within 6 weeks, but I think Sir William Gull was a sort of genius. Well, he said that perversions of the ego were the cause for anorexia nervosa, and I think I will tell you that we totally think different today. I'm not sure whether you are familiar with the American classification system, the DSM-5, and I will only refer to some small important points. You know that we have a very low body weight in anorexia nervosa. There is an intense weight phobia. That means there is a fear of gaining weight. And of course, there is an undue influence of body weight or shape on self-worthness. That means that if people are not they think there are nothing worth. Since DSM-4, the amenorrhea criterion was left. Well, I think that's quite easy to understand because for male patients, for example, the amenorrhea criterion wouldn't work. It wouldn't work for older females and also for those on contraceptives or for children. And children are becoming more and more important for us because we have many children suffering from anorexia by now. And I will tell you later about the problems we have with these small patients. When you talk about anorexia nervosa or when you diagnose this, you should always tell us whether the patient suffers from the restricting or from the binge eating purge type. Oh yes, that's important. That's the weight criterion. I would like to say something about that because there is some conflict about it. Well, the DSM-5 tells us that we should use BMI percentiles, and the German guidelines for eating disorders propose the 10th BMI percentile for children and adolescents as the weight threshold for anorexia nervosa, and that corresponds to the 10th BMI percentile in adults, which is 18.5. However, in ICD-11, they propose to take the 5th percentile for children and adolescents, which we cannot understand because why take a much stricter threshold for children and adolescents who have to grow and who have to develop? So we in Germany decided to stay to the 10th percentile. Yeah, and that's something quite new. I don't know whether you have already seen that in the Ukraine, but it has become very important, especially during the Corona crisis, and that is atypical anorexia nervosa. the criteria for atypical anorexia nervosa are the same as for typical anorexia nervosa. However, patients do not meet the weight threshold. That means they are at the 10th percentile or much above, and even overweight patients can have atypical anorexia nervosa. And when you look at epidemiological data, you might realize that today about 1/3 of inpatients in the United States, in the other Anglo-Saxon countries, in France and in Germany, suffer from atypical anorexia nervosa. One important thing in the history is that they were very often overweight before, so they can lose a higher amount of weight. However, the psychological symptoms and also the physiological consequences are very similar to those of AN. That means they are not less ill than those with typical AN. And I personally have seen very overweight patients with atypical anorexia nervosa who hadn't eaten anything for more than a week. So they were suffering from very severe starvation symptoms. So we are not very experienced with treatment with atypical anorexia nervosa. That's why we do not know how to define a target weight. And we also have limited information about the cause and outcome. But I would really ask you to look out for these patients because they are very often overseen. Sorry. So when you see the yellow face, it's always a sort of summary of that, what I had said before. So please remember, in contrast to DSM-4, patients are no longer made responsible for the illness. We have the suggestion to stay the 10th percentile as the weight criterion. And please always ask for weight loss in time. You know, many of my colleagues just put the patient on the scale, and that's not enough because then she probably has a normal weight. And if you don't ask how much weight she has lost in the last weeks or months, then you will oversee atypical anorexia nervosa. So it's never sufficient to know the current weight. Do not forget, that's it, atypical anorexia nervosa, and do not forget childhood anorexia nervosa, because that's also a problem. Many pediatricians oversee childhood anorexia nervosa. They think that a 10-year-old girl won't be able to develop anorexia nervosa, but that's not true, and it has changed during the corona crisis. I would also like to talk about the eating disorders in men. They look a bit different than those in females. We have a higher prevalence of eating disorders in homosexual or bisexual people. Unfortunately, men seek less treatment than women do, probably because they have a stronger feeling of stigmatization because it's a female disorder, so they don't want to have that. They often have less weight phobia than women, so during treatment it might be much easier to treat a male patient with anorexia nervosa because they also have less body dissatisfaction. However, they suffer from muscle dysmorphia, and that means that they love to have a sort of six-packs, you know, many muscles, and they do everything to have these muscles, and that makes the prognosis not very good because often after discharge from inpatient treatment, they make excessive exercises. And they sometimes eat special food, which is not very healthy, so that in some, the prognosis of male anorexia or male muscle dysmorphia is not much better than in females. However, we think that our diagnostic measurements or diagnostic instruments are not that good for a man, so that we probably oversee as many men who have eating disorders. Just very shortly to show you the difference. What is bulimia? Well, the most important symptom is binge eating and inappropriate compensatory behaviors. That means, for example, that people use that people induce vomiting, that they practice laxative abuse, and it is also similar to anorexia, that self-confidence is dependent on weight and shape. But please remember, the most important symptom is binge eating and not the compensatory behavior. Very shortly to binge eating. Binge eating has a very similar symptom as bulimia has. That means that they are also recurrent episodes of binge eating. And if you look at people, then people with binge eating are often more similar to those with bulimia than to patients with anorexia nervosa. And people who suffer from this disorder, who are normally older than those, for example, with anorexia, they eat very fast until they feel very full. They eat when they are not hungry, and mostly eat alone because they are afraid they could be seen by other people. And they are often very distressed, very depressed because of these symptoms. And again, the symptoms have to occur at least once a week for 3 months. Now we are going back to anorexia nervosa. We have a high comorbidity with anxiety disorders, especially with social phobia. And this is also very important for treatment, because if you oversee social phobia and you don't treat it, then it often happens that when the patient is discharged and she's very socially phobic, then she won't try to get into her peer group again. She will stay at home, then start again about thinking to lose weight, and you often have a relapse. So please look for social phobia, and when the weight is better, you should also try to treat this comorbid disorder. We have a high number of affective disorders, which often improve when the weight goes up. We have a high number of OCD. Please look for that. You know, when I started treating anorexia nervosa, and I think even 15 years ago, I didn't notice it. I didn't notice that patients had these obsessive compulsive symptoms. Only when I went into the rooms during the visit in the hospital, I saw that they had that they were very orderly, that they had very, that they looked that everything was symmetric. So please look for that. And I think the best would be to make a test, a sort of questionnaire to find out whether these patients suffer from obsessive compulsive symptoms. Substance abuse is not very frequent in adolescent anorexia nervosa, especially not in the restrictive form, however, in the binge purge type. And in bulimia, you often find substance abuse. So there is a big difference because between these two forms. And ADHD is rather seldom in anorexia nervosa too, but it might sometimes occur. Now, what is the prevalence? What is some comments to the epidemiology? Well, when you look at the lifetime prevalence, up to 4% of women suffer from anorexia nervosa. In men, it is much less, but please remember, I'm not sure whether we really diagnose eating disorders correctly in men. In young girls, it's about 2%. That means that about every 50th girl suffers from anorexia nervosa, and the mean age of onset is in adolescence with 15 years. And you know what always strikes me, and I think which makes one sad, is that the average duration of the disorder in adolescence is 10 years. So imagine that a young girl loses 10 years of her life suffering from a mental disorder. And I think so we have to do everything to help these patients so that they can enjoy their youth and their young adulthood. Well, of course, when I prepared this presentation, I looked for studies in Eastern Europe, and that was really difficult to find. I only found one study for the Ukraine, and in this study, they didn't look for the disorder, actually. They looked for eating disorder symptoms. They used this cough. This cough is a very short questionnaire, which has only 5 items. And it is, and you think that there is an eating disorder when the patient or the participants has 2 positive answers. And you see that by this cough, they found about 37% of participants in the Ukraine who suffered from some sort of eating disorder. However, I'm a bit skeptical because this questionnaire often overestimates the numbers. So we should be careful with this number. However, it shows that in the Ukraine, there are also many people who have the feeling that they suffer from some symptoms of an eating disorder. The same investigation was done in Poland. There were 20% of participants indicating eating disorder symptoms, and in Hungary, about 30%. Then I look at data from Russia, and there were about 30% of the female undergrads who were underweight. However, they didn't look for symptoms of anorexia. So the underweight could have had other reasons. Yeah, and this is not easy to understand, but probably quite interesting. And I will tell you, these are the numbers of patients with anorexia in Germany during the COVID pandemic, before and after the COVID pandemic. And it's a very great number because these are data from the health care system in Germany. So we have more than 4 million people at whom we could look. And I will just shortly tell you. The most important thing is that you look at the dark blue curve. That is the curve from 2019. That means the pre-COVID area. Then we have the year 2020 in the summit of the COVID crisis, and you see that there is a dip in hospital admissions, probably because parents were very anxious to bring their child into hospital because of thinking of an infection. But then in 2021, the numbers really increase. They go to a very high niveau, and a similar high niveau in 2022. That's the violet curve. And still a much higher niveau than in 2019 in 2023. That means that we had a difference of 27% between 2019 and 2023. That means that more than 25% were admitted to hospital more than in 2019. And the numbers are even much more are even higher in childhood anorexia. That is why I told you that we are really anxious that childhood anorexia is so much increasing. similar curves. However, the difference is, look at the year 2023 in comparison to 2019, and there is still a difference of 42%. That means we had 42% more admissions for childhood anorexia than in 2023 than in 2019. And actually, we do not know why there are so many children still suffering from anorexia nervosa, although there are no longer restrictions by COVID in 2023. Perhaps you can understand why I'm so much touched by these high numbers, because the prognosis, the outcome of childhood anorexia is very bad. You see that patients who get ill during childhood do not gain enough money when there are adults. They have the minimum income in the United States, much less income than, for example, adolescent anorexia nervosa or adult anorexia nervosa. That means that patients who suffer from childhood anorexia nervosa will probably not be able to gain enough weight to have enough for living. And the same is true for their social life. You see, this shows the marital status for these former children, and more than 40% do not have a partner or are not married in adulthood. So their social prognosis is very bad too. And this makes us believe that we have to fight for these patients, especially for these young ones, although we really do not know how to treat them really good. So again, the summary probably is the prevalence of anorexia in the young age increasing. We had a sharp increase during the COVID era, which is still there for childhood anorexia nervosa. I told you about men. Unfortunately, anorexia nervosa often takes a chronic course, and the mortality is still the highest of all psychiatric disorders. Now, some words about etiology. I won't tell you too much about it because it's rather difficult. But we know today is that there are important genetic factors. We know that there are metabolic factors, that there is probably an influence of the microbiome. I will tell you later, and that the chronic cause is often defined by the brain damage starvation produces for the human brain. Now, very shortly to the genetic factors, I think you can easily realize that there are some genetic loci that surpass the threshold. These are 8 ones, but there are still coming more. However, which I think is much more easy to remember is that female relatives of patients have a 10-fold higher risk to also suffer from an eating disorder. And the heritability in twin studies is 50 to 60%. So if you see a patient with anorexia nervosa, please always talk to her mother and talk to her the two of you. That means only the mother and you, because the mothers are often very ashamed to admit that they also had suffered from anorexia, and they try to hide this from their child. So I would really advise you to talk to the mother, because if the mother suffers from anorexia or had suffered from anorexia, that makes treatment often difficult. So it's very helpful to know. There is probably also an influence of the microbiome, and this is quite funny because in the first decade of the 21st century, it was found out that the microbiome has an important influence on weight. Well, how could the researchers find out? What they did was they applied the stool extract from obese mouse to a normal weight mouse. And what happened was that this mouse became very obese. And then they did the contrary. They gave stool extract from children who were starved with kwashiorkor, and the mouse became very lean and lost weight. So that was, I think, the first knowledge that led us to study the microbiome in anorexia nervosa, which is really complicated. However, first of all, we thought that the difference in the microbiome is based on the different weight, but this is not quite true. And this I will show you very shortly. This is the microbiome after 1 year of treatment. And the blue curve is the microbiome of healthy people, of healthy age and sex adapted controls. The gray curve is the microbiome of patients who had resumed their normal body weight after 1 year. But what you can realize is that the overlap is there, but it is not that much big. That means that there is still a difference in the microbiome of patients who have regained their weight and healthy controls. And this is the microbiome of the patients who are still ill, and there is even less overlap. That means that weight gain is not the only helpful measurement to help patients to get a normal microbiome, but we still haven't found any solution for this problem. There are other consequences of starvation about the microbiome, and one important organ is the brain. And I will show you this by a picture of a patient of mine. She came to us when she was 13 years old, and you see that there is already a brain volume loss. You see the rather large ventricles, and there is too much liquor in the outer sphere. And this girl came back 4 years later than when she was 17 years old. And you see that this brain is not normal at all. You see these very large ventricles, you see the loss of brain volume, and the problem is that this girl will most probably never be healthy again, because the starvation has done so much damage to the brain that this girl will never be healthy again. And that's what we know now by many studies, that the brain loss in anorexia nervosa is much larger than in other psychiatric disorders, and even higher than those found in schizophrenia. And it is correlated to the BMI. That means the lower the BMI, the higher the brain volume loss. For you, it is important that when you start treatment, you have to be aware that many patients have neuropsychological deficits which are caused by starvation, including the attention, the memory, and flexibility. And that makes psychotherapy in the beginning, when patients are severely underweight, very difficult. You know, when I meet girls that I had treated for anorexia some years ago, they always tell me that they do not remember the first 6 to 8 weeks in our clinic, and that shows me that they really had difficulties or had difficulties with their memory, and you notice it when you talk to them. Well, besides all these biological factors, which I already told you, there are, of course, other factors, the societal factors, and you see by the change during the corona pandemic that other factors than biological parameters play a role for the etiology of anorexia nervosa. Now we are coming to the assessment. The physical assessment is very important. You should look for the heart rate, which is normally very low. The body temperature, the pubertal development is often not age adapted. You should look for the complete blood count because the white cells are often very low, reduced. Please look at the biochemical profile, especially at the electrolytes and also the amylase pancreas, because there might be complications. Please look at the ECG, especially if you prescribe medication such as neuroleptics, then you have especially to have a good look at the ECG. And if you are not sure whether an organic reason could be, an organic cause could have provoked all the symptoms, then please also make an MRI or a CT. There are also some severe endocrinological changes in anorexia nervosa by the thyroid axis, the gonadal axis, the adrenal axis. And just a short tip. I always say that the FT3 is a sort of detective hormone because you can very easily diagnose if the patient has fasted during the last days, even if she has not lost weight, because the FT3 reacts very, very quickly, and you see within hours or a few days that the patient is not eating enough. So it helps, especially if you have outpatients. The non-responding of the gonadal axis is the reason why the patients do not menstruate. We have a very high cortisol, which shows the stress the patients are living in. And it is also important to know that the patient won't grow again because the growth hormone is very high, but the EGF1 is very low, so the patient will get a short stature if you do not help her during childhood and early adolescence. And this is also very important. It shows you the osteoporosis that patients with anorexia develop. And you see this is a rather severe impression of the osteoporosis. And what we have just learned is that you already get an osteoporosis even after the first admission for anorexia. That means that patients who only had anorexia for a rather short time already have a higher number of fractures than normal youngsters have. And so please never bed rest, because bed rest in anorexia nervosa patients makes osteoporosis much worse. And if you need bed rest, then only for a very short time during the days. That means not more than some hours, because otherwise the osteoporosis gets even worse. And some sport during the treatment of anorexia nervosa might even be helpful to prevent these changes of the bone. Well, the time is going on, is proceeding, so we have to get to treatment. Well, when should you admit a patient to hospital? Well, we have rather good guidelines by several countries, and they tell us that a BMI below the third percentile is an indication to admit a patient into hospital, or, for example, a complete food refusal. Then you should look at a metabolic risk, for example, the electrolyte disturbance. We talked about the cardiologic risk. We talked about low body temperature, and also have a look at dehydration, especially in children. You know, I've seen several children who wouldn't drink anything because they thought, in contrast to adolescents, that they would gain weight by water. And I even saw some children who wouldn't take their own saliva, wouldn't put it down because they thought that they would gain weight by their own saliva. So children are especially in danger to be dehydrated. There might be suicidality, which is an indication for hospital admission. There can be severe conflicts with caregivers, and do not wait too long if patients do not gain weight during outpatient treatment. Well, the most important target during treatment is, of course, nutritional rehabilitation. That means that you have to look for sufficient weight gain, because the weight gain and the BMI at discharge is the most important prognostic factor for the long and short-term course of anorexia. Well, how to define target weight? This is always under discussion, and this changes. It changes every 2 or 3 years. Well, in our guidelines, and even in the US American ones, the 20th to 25th BMI percentile is defined as a target weight. However, we have changed a little bit, and these are also the new, this is also the new information from other researchers in anorexia nervosa. Please look at the lifetime weight curves. That means if a patient always had a weight on the 10th percentile or the 50th percentile, then that might be okay, and you don't need to gain more weight till the 25th percentile. On the other side, if the patient always had a BMI on the 50th percentile, the 25th percentile might not be enough, and you will notice that, because if this is the case, the patient will most probably not have a resumption of menses. However, please be patient, because resumption of menses needs some months or even more to take place. And premenarche anorexia nervosa, that means children, patients with childhood anorexia nervosa, later need more time to start menstruation than those who had menstruated before the disorder. We do it now in Germany. We often try to assess the gonadal hormones, because if the gonadal hormones are increasing, you can be very happy and be sure that the patient will menstruate, and then you have also achieved the right weight for this individual patient. What is the expected rate of weight gain? Well, about 1/2 of a kilogram, 1/2 to 1 kilogram per week. And I think the refeeding syndrome was something we were all afraid of since, I think, about 5 years ago. However, today we have realized that the refeeding syndrome takes much more seldomly place than we had thought before. Especially if you regularly control the phosphate and is eventually substitute phosphate. So I'll show you the next slide and go back to this one later. You know, this was an investigation by Andrea Garber in San Francisco, and what she could show was that when the patients were fed on a higher calorie diet, that is the HC, the higher calorie diet, then the heart rate went up much more quickly than it did with the low calorie diet. And the same was true for the BMI. The BMI got higher much more quickly, much sooner than with a low calorie diet. However, I think that it is very difficult to give young patients, adolescents, children, 2,000 kilocalories from the first day on. So we start with 1,200 kilocalories and then increase every 2 days. But then back again, yes, you should always have a meal plan. If the patient is not able to follow this meal plan, try liquid food. If possible, make a normal table as you have at home, no food on a tablet as it is typical in German hospitals. And it might sometimes happen that you need a nasogastric tube. And for this, it is very important to inform the patient and to talk to her about it and to tell her that this is not a form of punishment, but just help if she is too ill to be able to eat on her own. I think this is an important information too. This shows the weight gain of patients with restrictive anorexia and with bulimic anorexia nervosa. Both groups got the same amount of calories, and what you see is that patients with binge eating, purging anorexia nervosa put on weight much quicker than the restrictive type, and the same is true for atypical anorexia nervosa. So the individual, so the meal plan should be very individual and not one for all. We do nutrition counseling in a group program for the patients. We also do meal support by nurses or therapists to help the patients how to start to eat normal again. And again, we have a summary. Weight gain is inevitable. We probably need higher calorie diets for the restrictive type. Please don't forget to adapt the target weight when the patient grows and gets older. Well, we talked about the individualized meal plan, regular weight control, I think is self-speaking, and you should make a readmission contract when the patient loses weight again. I have to hurry up very much. Actually, there is no medication approved in any European countries or the US. Sometimes it might be helpful to apply some olanzapine. However, there is not much good evidence. It is limited to a small weight gain, and its effect on psychopathology is much less clear. SSRIs are not helpful to gain weight. They are probably helpful to treat depression or OCD symptoms, but only then when the patient has already gained some weight, not at the 3rd or 5th percentile. Now, psychotherapy. Well, I already told you that you should not start psychotherapy when the patient is still underweight. However, during this time, you shouldn't leave her alone, but short talks and support are very important. And I often meet patients that tell me that this support and the confidence that the patient would overcome her disorder helped them a lot. So I would advise you to make short talks of about 15 minutes per day. And when she gets better, you can have longer talks and start psychotherapy. It is very important to never exclude the parents that that it is still a problem in Germany, unfortunately, that parents are prohibited to see the patient. This is of no help. It is very important to include them into treatment. We provide a psychoeducational group for the parents where they learn a lot about anorexia. And it is often helpful, this is advised by FBT, by the family-based treatment, that it is good to personalize the disorder to differentiate between the patient and the eating disorder, or fight against the eating disorder, but not against the patient. Well, family-based patient, that is the treatment with the highest evidence. In this form of treatment, parents are trained to refeed their children. They have a high responsibility for the eating disorder of their child, and they also have to prevent excessive exercise. And during the treatment, responsibility is given back. Then we have cognitive behavioral treatment, which you might probably know. And there is also a specialist supportive clinical management that is a sort of treatment which is mostly provided in practices or in hospitals. That means that the patient has a regular weight control, gets help to normalize her eating, and the patient also gets additional supportive psychotherapy. And again, there is no evidence that family is the origin or the primary cause of anorexia nervosa. I say this so often because I know that excluding the parents from the treatment has brought a lot of sorrow to many families. Well, I think I leave that because this is a psychoeducational group for parents. We do it about 4 or 5 times. In the 5th session, parents see parents of other patients who have regained weight, who are healthy again. So this is very helpful too, to include parents with lived experience, as we say. Well, yes, and we cannot talk about that tonight because it's we don't have enough time. But there are
take your time. Sorry, take your time.
Pardon me? Yeah, of course.
Start later. Take your time. It's important.
Okay. 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 Do you want me to go back to the psychoeducational group for the parents?
Yes, I think that's important. Yeah.
Yeah. Okay. The parents of every patient are asked to take part in this group. We always provide it after the visiting time. So when the parents see their child, they afterwards take part in this psychoeducational group, and the parents learn a lot. They are informed about the psychological and physical consequences of anorexia nervosa. We also inform them in a very detailed way about our treatment concept and about the milestones, you know, to improve the compliance. And I tell you, this really helps a lot. We also tell the parents how to refeed the child, for example, that we would not accept or not recommend a vegan diet. Vegetarian is okay, but not vegan. The parents are prepared for discharge, and they are also informed about the first signs of relapse so that they can seek for help as soon as possible. Well, during the last years, there has been some new development that is day patient treatment and home treatment. I will not talk about that tonight, but if you have questions, we can of course talk about that too. Something about the long-term cause of anorexia nervosa, which is not good. It still has, and I told you that before, it is still the highest mortality of all psychiatric diseases. Even after 5 years, the mortality is 5-fold higher than in age-matched controls. After 6 to 7 years, about 1/4 of persons with anorexia are still ill, which is a high number. And the professional career is very much disturbed. 18 years after the onset of the illness, 25% were unemployed in this study by the Swedish group. And this, although the patients are normally very clever and know a lot, and are really inclined to do a good work. And as I already told you too, in the 30-year follow-up by the Swedish group, patients had lost 10 years of their life to their disorder. And I had been to a congress in eating disorders in autumn last year, and there was a former patient, a patient with lived experience, as we say, and she had been ill for 14 years, and she gave us 5 rules. That's what she said. She told us that we always have to be aware that recovery is possible at any time, even after 14 years of illness. She told us that we should help our patients to find their inner motivation to recover. They told us that we should be human, don't be afraid to get close to our patients, and that's what I would recommend too. I think you can even tell your patient that you don't know how you can treat them further, and many of them will understand, and you can find common ways. You should address the underlying psychological difficulties, and you should never give up, and that was her most important point on your patients. So I'm coming to the end. I wish you peace, freedom, an independent future, of course, and happiness for all of the colleagues and for the whole Ukraine. And I think now we have still time for questions.
Thank you very much. So I will start to read the questions traditionally, but I have to check if you both do hear the translation.
Yes, I can hear it. Beate, can you hear the translation?
Yes, I only hear you, Jörg, but I think that's it.
Добре. Тоді
Yes, I can.
Добре, тоді я буду зачитувати питання від наших слухачів. І будемо дивитись, може будуть якісь ще у вас додаткові питання. Так, зараз, хвильку. Так. Пані Віра Дзьобас питає, через який час після початку лікування анорексії має відновитись регулярний менструальний цикл у підлітків? І на якому етапі треба звертатись до гінеколога, якщо вони не з'являються, скільки часу?
Yeah, I think that's a very good but also difficult question. You know, it depends very much on the amount of weight the patient could gain. if she has got her normal weight, her healthy weight, which would be about the 20th percentile, then it might even last several months till the resumption of menses takes place. So if you have the chance in the Ukraine, it would be very helpful to find out how the gonadotropins are working. Do you understand what I mean? Because if you see that the gonadotropins are increasing and the estrogen is increasing too, then you can patiently wait. You know, the most important point is that there is a basic level of estrogen. If you have this, then the danger of osteoporosis is very low, and then you can just wait. However, it might be necessary if the gonadotropins do not increase, then you mostly have to increase target weight. That means that you have to tell the patient that she still has to gain weight. And this is often a very big problem for the patients. But then you must tell her, we often show her the values of the hormones, that they are still too low and that she has to gain weight to get a normal menses again. If this doesn't happen, then you, of course, have to apply some hormones sometimes later. However, be aware that you should never apply oral hormones, but always by the skin, as in the menopauses.
Наступне питання. Чи використовується інсулін для лікування таких пацієнтів?
No, why should one? Because you know what you would do by insulin is you would lower the blood sugar, and that would be very dangerous for the patient. So you should never use insulin, with the exception that the patient also has diabetes, which not rarely happens. You often have the comorbidity of diabetes and eating disorders, mostly the binge purge type or bulimia, but only in this case. And then for the treatment of the diabetes, insulin is helpful, but never for anorexia nervosa.
Пані Аріадна Михайленко питає, чи призначають психостимулятори?
No, you should never prescribe psychostimulants for anorexia nervosa. I have seen very, very severe relapses under the applicants of stimulants, because, you know, when patients, for example, those with ADHD get stimulants, they lose their appetite. And if a patient with anorexia nervosa gets psychostimulants and even is no longer hungry, then it will be of great help for her to lose weight again. So I have been in the conflict when I had a girl with a very, very severe ADHD and a severe anorexia, to decide whether I should give psychostimulants. But you should try to take something else then and not take psychostimulants. It is really dangerous.
Пані Віра, ще одне питання було про ноотропи. Чи взагалі ви використовуєте ноотропи? Бо, як на мене, мені здається, що це щось таке недоказове, але чи ви використовуєте ноотропи?
Jörg, perhaps you can help me. I don't know what is meant by neurodrops.
Nootropes. I guess it's the whole class of non-evidence-based medicine, which is popular in Ukraine.
Okay, I don't know it.
Okay.
Do you know of what it consists?
Not exactly.
Is it a real medication, or is it more, you know, for providing nutritional supplements. Is it something like that? You don't know.
Але перейду до наступного питання. Від пані Віри Дзьобас. Що доцільно призначати на початку лікування анорексії у підлітків, щоб профілактувати психічні відхилення?
Do you mean to prevent psychotic episodes? Yeah. Okay. Well, normally patients with anorexia nervosa don't get psychosis. It's a totally different disorder, and so you don't need any medication to prevent a psychosis. It might sometimes happen that a psychosis starts with a sort of starvation because the patient is afraid to eat something because he thinks or she thinks that she is poisoned. But in typical anorexia nervosa, you don't have psychotic symptoms. It's a sort of delusion, as former researchers said, that you are too fat. But this has nothing to do with psychosis, and you should not use neuroleptics, perhaps with the exception of olanzapine, during a short period of the disorder when the patient is exercising excessively. Then it might be helpful to apply some olanzapine, but only in this case. You don't need, otherwise neuroleptics don't help to treat the symptoms of anorexia nervosa.
Пані Олена Снісаревська питає, чи є нова інформація щодо коморбідних з анорексією станів?
I tried to show you that there is a rather high comorbidity with anxiety disorders, with affective disorders, and also with OCD. These are the most important comorbidities in anorexia nervosa and also in other eating disorders. But there is nearly never a comorbidity with psychosis. Then it wouldn't be called anorexia any longer.
Пані Руслана Погорєлова питає, якщо у пацієнта є анорексія і депресія, і він відмовляється від психотерапії, чи може допомогти гіпноз?
Yeah, that's a good question. Well, the comorbidity with depression is very, very high. That means that about 60 to 80% of patients who have anorexia nervosa are also depressed. But the main and most important therapeutic tool is weight gain. You know, they have some experiments at the end of the Second World War in the US where they had young men where young men were starved and they hadn't had any anorexia before it, but they got very depressed. And when they were refed, then the depression decreased, the depression went away. So the first step is to put on weight. If the patient has gained weight and she is still very depressed, which happens, of course, and not very seldomly, then you can give her an antidepressant. If it is possible in the Ukraine, an SSRI would be good. I'm not sure whether you have that. Selective serotonin inhibitors. Yeah. But only if the patient has gained weight, not when she is coming to the hospital, to your practice, and she's still very underweight. Please wait till she has put on weight. The SSRI does not help in the underweight state.
Пані Віра Дзьобас питає, скільки часу спостерігаються підлітки лікарями після анорексії у Німеччині? І чи кожного пацієнта з великою втратою ваги консультує психіатр?
Yeah, I think this is a very, very important question. I think if you have the chance to see this patient after discharge every week, that would be really great. If you don't have if you don't have enough psychiatrists or psychotherapists, then please control the weight. This is very helpful if you just notice when the patient loses weight. And during the acute phase of the anorexia, and we propose at least 2 years after the patient has gained enough weight, she should be treated with psychotherapy. Of course, when she has stabilized, you can reduce the sessions. You don't need 1 session per week in the second year. If the patient is stable, then you see her every 6 weeks or every 8 weeks. But this is very important so that you will notice if she loses weight again. And many young people have problems. They have difficulties in a romantic relationship. They have difficulties with their education. They have difficulties with their parents, and all these conflicts can be the start point for a relapse. So it is good to see the patients in a regular manner, but it doesn't need to be every week if she has stabilizes her weight.
Пані Віра Дзьоба питає, якщо підліток вегетаріанка, чи збільшують кількість білків у дієті в перші тижні лікування? І чи є доцільність тривалого застосування вітамінів?
Yeah, and that's also a very important question. Well, we accept if the patient is a vegetarian because with a vegetarian diet you can enhance your weight, and that is totally okay. What you should do because of the osteoporosis is to apply vitamin D and calcium, because this is important for the bone. When the time of the adolescence is the most important time to increase bone mass, and for increase of bone mass you need vitamin D and you need calcium. So you should supplement these 2 substances. Other vitamins are not necessary as long as the patient eats enough fruit, eats enough milk, proteins, and things like that. Vegetarian diet is okay, vegan diet is not okay.
Пані Мирослава Кирилюк питає, які покази для госпіталізації у таких пацієнтів і частота зважувань за межами стаціонару для підлітка? На які параметри ми зважаємо для початку психотерапії?
Oh, I hope I got it okay. One question was how often patients should be weighed. Well, on an outpatient basis, you should normally weigh the patients once a week. However, if you notice that she loses weight, then you should see her twice a week. For example, the pediatrician or the general practitioner should try to see the patient twice a week. When she is rather stable with her weight, it's okay if you weigh her every 4 weeks. But I suppose I didn't get the other questions. Could you please repeat them?
Які покази для госпіталізації у пацієнтів?
Yeah. Well, I tried to tell that. Well, one is when the patient loses weight very quickly. For example, if she loses a kilogram per week, then it is really necessary to send her to hospital. Some people stop eating at all. They don't eat anything. That would be a very important point to send her to hospital. Or if you have already worked with the patient on an outpatient basis for more than 3 months and she hasn't put on weight, then please send her to hospital. Or if the patient has severe comorbidities, for example, if she is very depressed, if she is suicidal, if she has obsessive compulsive disorder, then please, in these cases, also send her to hospital. And if you are not, if you are quite unsure whether it is okay to send her to hospital, then perhaps you can talk to the hospital psychiatrist what he or she thinks.
Які параметри початку психотерапії?
Yeah. Well, when the patient has gained weight, I think normally at the 5th to 10th BMI percentile, you can start with psychotherapy. Before, as I told you, it is important to do supportive talks. But at this point, it is very helpful to work with the patient why a low body weight is so important for her. You know, we have to find out what the reason is that she always wants to lose weight. Some patients tell me that they need more attention. Others think they are not accepted by their peers if they don't have such a low weight. There are still others who think they are not worth anything, not even eating. So at that point, when the patient is somatically stable and you realize that she is able to talk about other things than just the meals or the weight, then please start psychotherapy. It is really helpful for these patients.
Пані Оксана Гайна питає, яка доза оланзапіну рекомендована і скільки часу?
Well, yes. Yeah. Well, you should apply olanzapine, especially in situations when there is excessive exercises. I think you all know these patients who are moving all day around, who are not able to sit down, who even move when they are lying in bed, and who always have these thoughts about losing weight and the urge to move so that they lose weight. In these cases, it is helpful to start with olanzapine. Of course, it depends on the weight of the patient and on the age of the patient. We start with very low doses, even with 1.25 milligram, which is very, very low. Then we increase to 2.5 milligram, and we normally stop at 5 milligrams. Some patients even profit from 2.5. And there are only few patients who need more. It happens that some patients need more, but this is not very often the case. And if you give them too much olanzapine, the problem is that they get too tired. And then, because they want to go to school, they want to learn, they wouldn't longer accept to take the olanzapine. So you have to be very careful to find the right doses. And I would suggest to try it on a lower dose, and if it doesn't work, then increase the dose.
Чи є якась роль вчителів шкільних, взагалі школи, в цій проблемі?
Yeah, of course. They have a great role. Teachers are very important. Well, I think one important job of the teacher is to recognize an eating disorder in school. You know, when they have a pupil who has lost a lot of weight, please be so kind and talk to the parents. Please be so kind and talk to the patient. And many patients told me that they had wished that their teacher had said something to them, but many teachers are afraid to talk to the patient. Please do so. Afterwards, the patients are really thankful. And then the role of the teacher is very important when the patient has regained weight and comes to school again. Then, you know, she shouldn't work too much, you know. Patients with anorexia nervosa, as I already told you, are often very clever and they are achieving very well. So it is better that they do not work too much than working all day long, which they want to do. And it is helpful by the teacher to tell the patient that the main goal is to become healthy and that it is not the main goal to be the best pupil of the classroom. Do you think that is helpful for the teacher? Yeah.
Пані Оксана Гайна питає, в якому стаціонарі лікують розлад харчової поведінки? В соматичному чи психіатричному?
Yeah, this is a very important question too. Well, in Germany, but I think we are very lucky, and you always have to think of that. We treat them on a psychiatric ward because the psychotherapy is very important. However, if you don't have enough beds in a child and adolescent psychiatric ward, then please send her to a pediatric ward because it is better to get any treatment than no treatment at all. And perhaps you can do something like consultations, you know, that a psychiatrist goes into the pediatric hospital and helps the doctors there and the nurses there to help the patient. But the best thing is to have a psychiatric unit because then you have more facilities to provide the patient with different sort of therapies, such as occupational therapy, physical treatment, school, etc.
Пані Руслана Погорєлова питає, якщо пацієнт дуже повільно набирає вагу, біля пів кіло на місяць, має тяжку депресію з суїцидальними думками, приймає есциталопрам і оланзапін, але відмовляється від психотерапії. Що можна ще запропонувати?
I would actually, this patient I would send to hospital because it is nearly not possible to handle such a patient on an outpatient basis. And then in the hospital, you should provide her with at least 6 meals per day. That means she should eat the main meals and also additional meals in between. And if she is not able to eat them, then provide her with liquids, liquid food, which you, for example, otherwise give patients who have cancer or something like that. And if she is still not able to drink the liquid food, then you have to apply a nasogastric tube, which is sometimes necessary. But you should tell the patient that, as I already said, that this is not a sort of punishment, but that this is the only way how you can help her, and that she is too ill to be able to eat by herself, and that's why you help her with a nasogastric tube. And the majority of patients really accept that. In our unit, patients even go into the city with their nasogastric tube. A nasogastric tube does not mean that you have to use constraints, that you have to do the treatment against the will of the patients. Try to persuade her and tell her how anxious you are, that she will never get healthy again if she is not refed.
Пані Наталія Грамаш питає, чи є доречним застосування антидепресантів, наприклад, есциталопраму та флюанксолу при нервовій анорексії та булімії?
Oh, I think you have to repeat that about the antidepressant.
Чи є доречним застосування антидепресантів, наприклад, есциталопраму та флюанксолу при нервовій анорексії та булімії?
Yeah, I got it. As I already said, it is sometimes helpful to use, for example, escitalopram or fluoxetine when the patient has an eating disorder and is also depressed. Fluoxetine or escitalopram do not help against anorexia nervosa. There have been many studies and no study could demonstrate that there is any effect on weight gain. So please use the antidepressants when the patient has gained weight, is about the 10th percentile or has a BMI of 18.5, then you can try antidepressants, but only if the patient is depressed or if the patient has obsessive compulsive symptoms, but not for the weight gain. And that is often a problem. Many doctors think that the antidepressants are helpful for the weight gain. They are not helpful. This has been proven in many, many studies.
Пані Людмила Федас питає, чи можливо замість олензепіна застосовувати маленькі дози рісперидона?
Yes, there have been some studies with risperidone, and you can use it if you don't have olanzapine or if there are any problems with the olanzapine. However, in anorexia nervosa, there are much more experiences, clinical experience with olanzapine than with risperidone. There has been a rather large study in the US that could show that there was a small weight gain by olanzapine in a randomized controlled trial. With risperidone, we only have very, very small RCTs. So we know much more about adverse effects of olanzapine in eating disorders than with risperidone. So if you can, if it is possible, take olanzapine. If you don't have the chance, then take risperidone. And I just remember I forgot something very important, because the question before was also on antidepressants and bulimia, and there it is really different. You may apply fluoxetine. This is mostly This is mostly research. There has been the most research on fluoxetine for bulimia. However, you have to take rather high doses. You need about 60 milligram of fluoxetine to treat bulimia. So it would be the second step. Please first try it with psychotherapy. The best is cognitive behavioral therapy in bulimia. And if you don't get further, if you don't succeed, then take an SSRI in a rather high doses, because the low doses which are used for depression don't work for bulimia.
Я візьму ще 3 питання, бо вже дуже пізно і нам треба нашого спікера відпустити. Тому ще 3 питання і все. І так, наші 3 питання будуть такі. Пані Олена Смашна питає, чи практикують застосування анаболічних гормонів при дистрофічних змінах тканин та органів при анорексії?
No, I wouldn't do that because, you know, then you make rather severe endocrinological changes, and many of these anabolic hormones also have effects of male hormones. So this is really not helpful. You should not do that, and you should try to give enough food and to help her by psychotherapeutic measures, but do not give anabols. They have been used, I think, many decades ago and haven't been of any help.
Наступне питання від пані Наталії Гармаш. Які протитривожні препарати ефективні при поєднанні анорексії та тривожного розладу?
Yeah, well, if you have a severe anxiety disorder, you can also take the SSRIs, that means the serotonin inhibitor. But again, please wait till the patient has gained some amount of weight. And for anxiety disorders, cognitive behavior treatment is also very, very helpful. You know, you can do exposition. For example, if the patient has social phobia, you can help her to try this or that social situation. With a reward, you can make a program with her. However, if the anxiety is too severe, then you can actually use antidepressants, SSRIs.
На якому етапі використовують фізичну терапію, фізичну реабілітацію для таких пацієнтів?
Yeah. Are we talking about the same? Are we both talking about physiotherapy? Do you mean that? Yes. Okay. Well, I think you can use it right from the beginning. Our patients do a sort of very do a very small sports program, even if they are still underweight, because it helps the patients a lot. What you can do is something like an isometric training. Do you understand what I mean? You know that isometric training are exercises that do not need many calories. You know, the patients try to strengthen some muscles, but they don't run around, and this is often seen as very helpful. I would really start rather early. Physiotherapy is a good means also to get confidence of the patient, because many of them like it a lot, and then you have a method to get in contact with her.
І останнє питання від мене. Наскільки легко такій дитині або такому підлітку отримати допомогу в Німеччині? І хто за це сплачує?
The last part of the question was who is what?
Наскільки легко отримати цю допомогу, хто сплачує за неї?
Yeah, this is a very good question. Well, in Germany, we have a system of health insurances, and the health insurances pay for the treatment. They pay for the hospital treatment, they pay for the outpatient treatment, and they also pay for psychotherapy. However, your question is very good because, and this is really a pity, it often takes a long time before you get an outpatient treatment place. That means it is not that easy to get psychotherapeutic treatment for anorexia nervosa. And unfortunately, many of our psychologists and even pediatricians are not very experienced with this disorder. Therefore, for us, it is very important to inform many therapists, many doctors about this disorder so that these patients are helped. But it is not a question of money because every patient is in a sort of health insurance.
Я дуже дякую професору Beate і професору Йоргу за цей вебінар. І ми всім дуже дякуємо, хто був з нами. Це було, до речі, дуже багато людей. Навіть на якомусь етапі 594 людини на цьому вебінарі було. Я дуже вам всім дякую і я бажаю всім тихої ночі, наскільки це можливо. Бо в нас давно не було тихих ночей, але може нам повезе і ця ніч буде тихою. Jörg, would you like to say a couple of words in the end?
Yes, I really wish you all the best, and we often think of you, and I hope you will really have a better future.
Professor Fegert?
Thank you very much, Beate, that you have done that excellent talk. And I think at the end I understood that question was about nootropics. We pronounce it the other way around, anti-dementia medication.
Ah, okay.
You would say that does not help in anorexia.
No. Oh yes, thank you, Jörg. Thank you.
But it took me some time to
Yeah,
get the...
yeah.
So,
And I'm not
thank you
so
all.
much used to treat dementia.
And thank you to UNICEF Ukraine to organize everything, to the translators for the support, and especially to you, Beate, for that excellent presentation. Thank you. Have a safe night. Have a good night. Bye.
So have
Thank you.
Thank you so much.